Hello, my name is Neda. I'm here to present you a patient case of LM. She is 62-year-old African American female who was seen today in the internal medicine clinic for a follow-up appointment for blood pressure evaluation and overall medication management. LM was seen in the clinic 2 months ago and was started on atorvastatin at that time. Her previous blood pressure measures were 161/87 and 164/83 when repeated. She says she has been trying to cut salt out of her diet and walking more. She is willing to pursue therapy for any and all of her conditions. However, she is not interested in quitting smoking at this time. Her past medical history: she has hypertension, dyslipidemia, and arthritis. Family history: her mother deceased from dementia, her father alive with heart failure and hypertension. And for her social history, she is a current smoker, smokes 1 pack per day, walks for 15 minutes daily, and married for 35 years. She has allergy to penicillin with hives, and the medication that she is taking is atorvastatin 80 mg once daily, multivitamin 1 tablet once daily, and Advil 200 mg 4 times a day as needed for arthritis. The high priority problems are hypertension and cardiovascular medication management. Low priority are dyslipidemia and arthritis. For the assessment of her disease: first, hypertension. The patient experiencing uncontrolled stage 2 hypertension as evidenced by her current blood pressure, which is 162/85, and when it was repeated it was 165/86. She was seen 2 months ago and her blood pressure measures were almost the same readings. While she had similar readings in a pharmacy blood pressure measuring machine, and this rules out what's called white coat hypertension and confirms diagnosis of hypertension. She has hypertension without other comorbidities such as chronic kidney disease, diabetes mellitus, heart failure, myocardial infarction, AFib, PAD angina, or CAD. Contributing factors are age, race, ethnicity, gender, cigarette smoking, family history, since that her dad has hypertension, and OTC Advil that she is taking. The patient is not taking any medication for hypertension but has been trying to cut salt out of her diet and walking more. The goal of therapy is to reduce associated morbidity and mortality from cardiovascular event. For the assessment of dyslipidemia and cardiovascular event risk, first, for the hypercholesterolemia that the patient has, it seems controlled according to her recent lipid panel, with total cholesterol 162, high density lipoprotein 50, low density lipoprotein 78, which are within normal limits. However, the triglycerides are still above level 168, but comparing to the previous reading, the patient is responding greatly since the reduction is almost 38%. The patient has a 10-year atherosclerotic cardiovascular disease risk factor of 18.4%, which is considered high. The patient's lab test showed normal blood glucose with 2-hour glucose challenge of 111 and A1C 4.5% and negative micro or macro albuminuria. So that rules out any defect with her kidneys. Although she has low serum creatinine, which may be due to low protein intake because the patient does not have any other causes such as severe liver disease or muscle dystrophy. Also, she has normal TSH level and liver functions. Therefore, as I mentioned before, she doesn't have any other comorbidities may precipitate cardiovascular events. For the assessment of the drug therapies, for hypertension, the patient hasn't been started any medication for hypertension to be assessed. However, for dyslipidemia, atorvastatin 80 mg once daily seems controlling her cholesterol well, as evidenced by her lipid panel, as I mentioned before, except for the triglyceride, which is still above the recommended target level. So continuing atorvastatin is still necessary for achieving more reduction and prevent CV event. For the plan, I recommend both pharmacological and non-pharmacological therapies. The pharmacological therapy, I want this patient to start taking lisinopril 10 mg once daily and hydrochlorothiazide 12.5 mg once daily, then titrate up to 20 mg and 25 mg once daily respectively within 2 to 3 weeks if the patient tolerates initial doses. Also, this patient should continue taking atorvastatin 80 mg once daily. The non-pharmacological therapies include DASH diet, physical exercise for 30 minutes, at least 5 days a week, smoke cessation, maintain normal body weight within mass index less than 24.9, and reduce salt intake. The blood pressure target for this patient is 130/80 as recommended by the new guideline. Follow up within 1 month to reassess medication efficacy and non-pharmacological patient response. Also to see if the lisinopril dose could be or needed to be titrated up again to 40 mg once daily. The rationale behind those recommendations, according to the guideline, stage 2 hypertension should be treated with 2 or more antihypertensive agents with 2 different classes or mechanism of action. This comes with class 1 level of evidence B. Section 10.1.1 in ACC/AHA guideline 2017 shows that Black patients and other patients age 60 or more tend to have greater antihypertension effects with calcium channel blocker and thiazides that make them ideal as ideal first-line monotherapy or as initial agents in multi-drug therapies. Recommendation number 58 in the dyslipidemia guideline 2017 presents that further reduction in low-density lipoprotein cholesterol for high-risk patients beyond established target using statins leads to more reduction in atherosclerotic cardiovascular disease, and this comes with grade 1 level of evidence A. So here atorvastatin 80 mg is considered high-intensity statin and suitable for this patient since the patient has a high 10-year ASCVD risk which is equal 18.4. The non-pharmacological therapies are recommended by ACC/AHA guidelines for controlling hypertension, also for controlling dyslipidemia, and so to reduce cardiovascular events. Non-pharmacological therapy provides 20 to 30 mmHg reduction in the systolic blood pressure according to American Family Physician, especially if that patient adheres to it. For the monitoring, we want to monitor hypotension regarding both lisinopril and hydrochlorothiazide. However, for lisinopril, we want to monitor serum creatinine, BUN, potassium, and consider baseline liver functions test and monitor for jaundice as a sign of liver failure. Regarding hydrochlorothiazide, We want to monitor serum and urine electrolytes, uric acid, blood glucose, and renal and liver functions. Patient education plays an important role. We want to encourage this patient for encouraging smoking cessation, and also this patient should be aware of side effects she may experience from those antihypertensive agents. For example, lisinopril causes hypotension, dizziness, high serum creatinine, syncope, headache, and cough. Hydrochlorothiazide may cause hyperglycemia, hypotension, dizziness, headache, and electrolyte disorder. This patient also should avoid systemic non-steroidal anti-inflammatory when possible and consider alternative analgesics such as acetaminophen or using topical anti-inflammatory, non-steroidal anti-inflammatory. Adherence to medication is crucial and plays a major role in controlling disease. A flu shot is recommended for this patient. There is a couple points I want to discuss regarding prevention of cardiovascular event as requested by the patient. So here we will consider it primary prevention because the patient doesn't have any cardiovascular event before. The United States Preventive Service Task Force guideline addresses the decision to initiate low dose of aspirin for patients 60 to 69-year-old who have a 10% or greater 10-year cardiovascular risk should be an individual decision, and this comes with grade C level of evidence. Because it comes as grade C, I looked and I searched for some trials to support my final decision regarding the primary prevention. So I came with a systemic review that shows that aspirin for primary prevention offers a modest benefit for a patient with high atherosclerotic cardiovascular risk. It is primary controlled randomized trial that focused on patients with hypertension. Aspirin significantly reduced major cardiovascular event with a relative reduction of 0.85. This comes with 95% confidence interval 0.73 to 0.99. Another meta-analysis addresses that the use of low dose of aspirin is beneficial as for primary prevention of cardiovascular disease with risk ratio 0.9, and also it comes with different reduction in myocardial infarction and ischemic stroke and all-cause mortality. The patient here does not fit with a COMPASS trial that regarding the rivaroxaban as the provider suggests. So because she doesn't fit the trial because participants there had at least one cardiovascular event and they were seeking secondary prevention using rivaroxaban alone or in a combination with aspirin. So regarding those findings, I do recommend low dose of aspirin such as 81 mg once daily for this patient. Only aspirin but not the rivaroxaban for primary prevention of cardiovascular disease. Thank you.